Hi there. Today we're going to talk a little bit about the crisis interventionist role when working with terminally ill patients. So first off, we want to talk about what the definition of terminally ill is. A terminal illness is any disease that cannot be cured or adequately treated and that is reasonably expected to result in the death of your patient within a short period of time. And now that we know what that definition is, we want to talk a little bit about what some of the terminal illnesses that you may come across when working with clients as a crisis interventionist or social worker might be. So we're talking about any cancers that are metastatic or stage 4, recurrent following therapy, or are considered inoperable, cancer of the esophagus, liver, pancreas, gallbladder, or brain, small cell or oat cell lung cancer, mesothelioma, leukemia, dependence on a cardiopulmonary life-sustaining device, chronic heart failure or pulmonary failure, anyone who has been comatose for 30 or more days, a newborn who was born with a fatal genetic defect, or any person who's awaiting a lung, heart, liver, or bone marrow transplant. So now that we know what some of the things that you may come across as a crisis interventionist working with terminal illness patients might be, we want to talk a little bit about support. We feel like one of the most important interventions that can be done with a terminally ill patient is going to be identifying a proper support system to help them through this process. So we've chosen to break this down into 3 or 4 different sections. We're talking about family and friends. We're going to talk about options for additional care, a discussion about the support that's going to be needed for possible situational mental illness, and then also the stages of grieving. So starting with family and friends. It's really going to be important to help your client identify those who can be there to support them emotionally, physically, and possibly even financially through this process. This is going to help them cope with their terminal illness diagnosis, and it's also really important that the support system is aware of what the client's needs are going to be, as well as their own proper self-care, because caring for terminally ill patients can be very hard on the caregiver, and this is going to help them manage that time. Some options for extra care. So we've got 3 main options that we want to discuss. We're going to talk about assisted living, nursing home, and hospice care. So assisted living is generally a really appropriate choice for anyone who is not incapacitated by their illness. If you find a good assisted living facility, it can be a great, pleasant community that offers the help and support that these clients are going to need, possibly for daily living activities such as cooking, cleaning, running errands, and that type of thing. However, these facilities can be very expensive and are often private pay, so you want to be sure to talk with your clients about their financial situation and how they're going to cover those costs. Secondly, we've got nursing home care. So this is going to be an appropriate option for someone who is incapacitated or is unable to meet their own daily living needs. Dementia patients are very good candidates for nursing home care because they might need that around-the-clock care. This option can be private pay, or sometimes there are state-run facilities that are covered by Medicaid. And then finally is hospice care, and hospice is typically provided at the end of life. Can be provided in the client's home or in a hospice care facility. The goal of this type of care is just to offer quality end of life and support for the client until they're passing. Now we're going to talk a little bit about situational mental illness. Major depression is highly associated with clients who have been diagnosed as terminally ill due to their intense suffering, pain, and emotional that they're going to be feeling throughout this time. Sometimes they're having that inability to cope with terminal illness. So often physicians do not initially recognize these signs of depression, and so it's going to be our job as the crisis interventionist or as a social worker to help the physicians to see what the client is going through and to reach out for that extra care. This is going to give them the best possible end-of-life experience. Clients also should be monitored for situational mental illness as far as suicidal ideation goes, because that's pretty common with terminal illness as well. Next, we've got anxiety. So anxiety can have physical, social, psychological, and spiritual effects on the client. Anxiety can show itself as sweating, restlessness, insomnia, panic attacks, worry, tension, or in many other ways. You want to provide the client or refer them for counseling, for coping skills work, and supportive therapy, because these can help ease the anxiety that your client is feeling and help them through the process. And then finally, delirium. Delirium is very common in the very final stages of their illness, and so you want to be careful to differentiate delirium from from anxiety or depression. It's going to often show itself as a cognitive impairment or fluctuating levels of consciousness. And then finally, we're going to discuss the 5 stages of grieving. So the stages of grieving are going to be universal, and therefore it's really important to help the client and their support system to understand what to expect and how to work through these stages. The 5 stages of grieving are denial and isolation, anger, bargaining, depression, and acceptance. So Supporting your client through these stages is going to help ensure that quality end of life. Thanks so much.
Trying to decipher what doctors are saying, making plans for treatment, all while attempting to cope with the news just received, is very overwhelming for a client. So this is why the last thing that people really want to worry about is the cost of treatment, if insurance will cover for treatments, and where this will leave the client and their family financially. In reality, it is that high cost of treatment that plays a role in every aspect of the client's care. There are three main types of insurance. There's commercial health insurance, Medicare, and Medicaid. And then there are also many clients who are unable to pay for health insurance at all, which leaves them with unsurmountable medical bills. Oftentimes, individuals are very healthy and have never had medical issues in the past, so they choose the less expensive plans, which do not cover as well as other plans. This leaves room for clients to face high deductibles, lower quality of care due to limited available resources. Oftentimes, insurance companies must approve specific nursing homes, home health agency services, medications, doctors, hospitals, and sometimes even the transportation that is provided. Many clients are unable to drive themselves due to their physical condition or medications that they are on. Oftentimes, those clients also rely heavily on family and friends for transportation. However, some clients do not have that option. In larger cities, there is public transportation at low cost. However, in more rural areas, public transportation is not an available asset. Depending on the transportation agency, sometimes Medicare or Medicaid will cover the cost. However, most transportation services require a minimum of 24-hour notice for transportation, and often those services do not operate during the weekend hours, leaving clients frustrated. Ambulance transportation is available. However, if it's not a medical necessity, then the client could face up to a $700 bill depending on the agency that they go through.
Many times, people who are faced with a terminal illness crisis don't know what to do about treatment or care, or even if they want care. They may not know what their options of care are. When faced with a terminal illness, people have some options for care, a few of which include palliative care, hospice, medical treatment, physician-assisted suicide, and no care. Palliative care and hospice are two major types of care which people with a terminal illness may receive. According to researchers Sherry Weisenflue and Ellen Chakai, the field of hospice and palliative care has grown exponentially since its beginning in the 1980s. However, people often wonder what the difference between the two is. According to researchers at the Mayo Clinic, hospice care is for people at the end of their life with 6 months or less to live. Hospice is not meant to cure any diseases. It is meant to make a person comfortable and provide as much quality of life as possible before they pass. Hospice services include reducing pain and addressing physical, psychological, social, and spiritual needs. Palliative care is similar to hospice because it provides similar services. For example, it provides pain management and symptom management and emotional and spiritual support to people with a terminal illness. However, people with chronic or debilitating illnesses may also use palliative care. Also, palliative care is used with life-prolonging therapies. So, in summary, hospice is used for comfort at the end of life, and palliative care is used for comfort while trying to prolong life. Another form of care for a terminal illness is medical treatment prescribed by a doctor. For example, if the terminal illness you have is cancer or some sort of stage 4 cancer, there are some different types of treatment which a person can go through in order to prolong their life. According to the National Cancer Institute, different treatments for cancer include surgery, chemotherapy, radiation therapy, immunotherapy, and many others. With many terminal illnesses, there is some form of medical treatment or drug which you can receive in order to prolong your life. Another option people sometimes consider is physician-assisted suicide, or PAS. PAS has only been legalized in some countries and states in the U.S. According to the researcher Piera, PAS is defined as the act of self-administering a lethal drug which has been just prescribed by a physician. This option is often considered when people have a terminal illness. This option is often considered when the terminal illness is going to cause grotesque suffering and pain for the individual before they pass away. In order to avoid such suffering, people may perform PAS before the pain begins or becomes too much to bear. One final option is no treatment or care. Sometimes when people find they have a terminal illness, they decide they don't want to do anything to prolong life, or they don't want to cause any financial burden to the family. If they choose to, they may refuse treatment and let the illness take its course. Sometimes people just want to go home, be with their family, and live whatever life they have left.
So I'm going to be talking about the aftermath of a terminal illness. The things that I will be addressing is PTSD, grief, and losing a loved one. So PTSD, as most of us know, is post-traumatic stress disorder, and this can form for the patient who just found out they have a terminal illness, and also for the caregiver or for the family. PTSD can be found with a terminal illness because this is a tragic event that disrupts the normal life. And this isn't just for, like I mentioned earlier, this isn't just for the client or the patient, but also for the family as well. The family and patient often face several tragic events even after the first diagnosis of the illness, because the illness may become more severe after treatment, such as chemo or radiation. So this just means that a lot of times, like for example, someone who has a terminal illness such as cancer, if it's stage 4, a lot of times they'll do like chemo or radiation, and then they get to the point where they're doing that, and then it actually makes them even more sick or relapses worse than it did the first time they even found out they had the disease or illness. So a lot of times it's just it's like reliving the event over and over and over again. So this can be very hard for the patient as well as the family. And the next topic is grief. As Paige mentioned earlier, there are 5 stages of grief according to Elizabeth Kubler-Ross. She identified these stages of grief in 1961 when she was working with cancer patients. The first stage is denial. This stage is the first one just because this is typically the shock stage. So this is when the patient or the client finds out that this is the first time they're finding out that they have this illness. A lot of times they're still in disbelief. They just are in total shock. This can be hard for the family because a lot of times the patient may choose to do hospice, and if the family just doesn't really understand the condition and how serious it is, then they don't really understand why the family member would be choosing hospice. The second stage is anger. This stage is the point where the patient is often wondering why this happened to them. This can be particularly hard for people with terminal illness because sometimes there's no answer as to why this happened. This can be even hard for people who are spiritual because, like I said, there's just no answer. There's no reasoning a lot of times for why someone has cancer or someone has a different type of terminal illness. It just happens, you know. You could do the same exact thing as someone else or do even better things like, you know, have a healthier lifestyle or, you know, just different things, and it affects you and not another person. There's not really any reasoning as to why, so this can be particularly hard for the patient or the client. This is also hard on the family because the patient or client becomes angry and unconsciously will take their anger out on people who take care of them or their loved ones, and the family, you know, they just don't really understand. The good thing about this stage is once they get past this stage, there's a lot of room for acceptance and for peace. So it's more comforting after they get through this stage. The third stage is bargaining. And during this stage, this is where the patient tries to do trade-offs. So, for example, they would say, if I get to see so-and-so get married or so-and-so graduate, then I'll be okay with dying. Then I can, you know, move along, then I can I'll be okay with the disease or the illness. I'll be accepting towards it. The problem with this is obviously that some people, if they're relying on their kids to graduate, what if they don't graduate? What if they don't get married? What if that doesn't work out? Then that's obviously just almost a big disappointment. The fourth stage is depression. This stage is where the client or the patient is just exhausted. They are so tired, they have no energy left, and they're just, they just want to be done, basically. This is the stage where it's very important for social workers or therapists to really seek and find who their support is. So find out who their support system is. If it's their family, then you want to be on the same page as their family and giving this client or this patient as much support as possible. And then the fifth stage is acceptance. This stage is where the client or the patient has really accepted the fact that something is happening or something is going to happen. This is where the patient can truly live their life. So this is really where you want your patient or client to eventually end up. I like how Elizabeth Kubler-Ross says, this is not the point where the patient is giving up, but where the patient can see through the pain, the depression, fear, and anger. So initially, this isn't the stage where they're saying, I'm going to die. Like they're not, they're actually just, they've accepted it, but they're willing to move on and to live their life to the fullest. They're not holding anything back once they get to this point. And then the last stage, or not stage, but the last point that I have is the loss of a loved one. And according to hospicenet.org, there are so many different types of ways to cope with death. The way a person grieves differs among others by how their personality is and the relationship they had with the person who passed away. A person copes with their grief by their personal experience with the illness, the ways in which the illness advanced, the person's religion and/or culture, mental state, support systems, and what the person's financial status looks like. So a lot of these things, like as I had mentioned about the person, their personal experience with the illness. So how much knowledge do they really have about this illness? The second one, where it talks about the way in which the illness advanced. So was it a prolonged illness? Was it fast death? What types of those things? That all matters on how a person copes, and each person is different. There are two different types of forms of support. One may receive if they need additional support during this difficult time. For most people, their support system comes from their family and friends, even doctors or nurses. So most people, they just don't really need the extra support, but there are people who do. And the two choices for those are grief counseling and grief therapy. Grief counseling is for people who are mourning that have normal reactions to the grieving process. This type of counseling can be attained by having a professional trained person or by having a self-help group therapy. This would be kind of like AA, but the whole group would be they would all be part of the bereavement process. So they would all be dealing with the same thing that obviously the client or the patient would be. And then there's grief therapy, and this is used for people who are experiencing serious reactions due to their grief. So again, grief counseling is that's usually when the patient or client needs help with the mourning process, but they're having normal reactions. Grief therapy is when they're experiencing serious reactions due to their grief. This one, the therapist will try to talk to the person to see if what they are experiencing is normal emotions for this person. Grief therapy can be individual sessions or grief counseling, or like grief counseling, it can be like a group as well. So it could be like an AA, like I had mentioned earlier.
For cultural diversity, I looked at three different groups, if you will. I looked at Chinese persons who have advanced cancer. And in the articles and research I found, it said hope plays a significant role in terminal illness. And that hope provided an important coping resource reflecting key needs and concerns at the end of life for the Chinese. Families of the Chinese individuals who had the advanced cancer were the fundamental social support, as well as the psychological and emotional support for the family members. For the Chinese, life is lost forever when death occurs, and therefore heroic measures um, to sustain and prolong life should be implemented, and at all costs. Also, Chinese older people with advanced cancer coped with it by hoping for the best but preparing for the worst. The best being that either they go into remission or they find a cure, and the worst being death. Medical science continues to subscribe to a narrative of progress, which sustains hope that the treatment, of the disease will end in either the alleviation of suffering um, as it becomes ever more effective of treatment. I also looked at Portuguese patients and dignity therapy. And psychological distress is a major problem for terminally ill patients. And psychological suffering is um, also framed in terms of loss of dignity. And so, dignity therapy is a brief psychotherapeutic approach with the aim of of bolstering the patient's sense of meaning and purpose, reinforcing a continued sense of worth, and within a framework that is supportive, nurturing, and accessible for those near death. Dignity therapy offers patients the opportunity to talk about issues that are important to them and that matter the most to them, to share moments that they feel are the most meaningful, and to speak to things that they would like to be remembered for or by, and to offer those to their friends and family. Participants who use dignity therapy are significantly more likely than patients just receiving standard palliative care to experience reductions in depression ratings immediately post-treatment, with improvement being sustained throughout subsequent follow-ups, with the exception of a 30-day evaluation. The final group I looked at was Ethiopians seeking health services during a terminal illness. And in Ethiopia, modern and alternative health services are considered complements rather than alternatives of each other. And contact with modern health services in terminally ill patients is relatively high. It's at about 87% are reported to have ever visited a medical facility. For AIDS patients, that figure is as high as 96%. Only 38%, however, of terminally ill patients are reported to have been admitted to a hospital or clinic for more than a day. Fewer than 25% spent more than a week in a medical facility, and that fraction goes down to even lower, less than 24%, to actually have passed away in a medical facility. Only 6% of the terminally ill visited just a traditional healer or a water source only, without any type of reported contact with a modern medical facility. And the duration of illness itself is the most important predictor of modern medical services used in Ethiopia.
Hi, I'm going to be talking about 3 areas in this panel discussion. The first one is African Americans in relation to the quality of life. The second one is Latinos and bereavement. And the third one is Belgians and information disclosure. Okay, so the first one is about African Americans and the quality of life. And studies seem to show that those who are connected with their spirituality or believe in a higher purpose or are connected to something more than themselves, have a more positive quality of life, and are able to handle stressful situations and are better with coping skills because they can kind of reach out to something, or they have something to kind of keep them grounded. Spirituality is important in the aspect of terminal illness. Some people seem to believe that the end of life is sometimes not as sad as some other people might think it is. They might think it's like they're going home or something, where they're not. Where they're not kind of going away, and that they'll still be with them, like in spirit. Also shows that spirituality is important to many African Americans, and it's kind of a vital part of their everyday life. You know, they wake up and pray, or pray before they eat, or pray before bed, or all of the above. So that's also really important. And that, that individuals who have the support of their family and friends and healthcare professionals are able to cope during difficult times of their life. Okay, so on to Latinos and bereavement. 5 cultural commonalities of the Latino population. The importance of family is a really big one. It's kind of a culture that's centered on family and family values. Maintaining respect for others is another one. It's just kind of a basic belief that you just respect everyone that you come into contact with. You definitely respect your elders. Upholding personal dignity is kind of a way that they interact with other people and the way they live their life. Also believe in fate a lot, that people are not always as in control of their destiny as they want to be, that some things happen and you can't really control it. Religion and spirituality have a significant influence, religion and spirituality have a significant influence, kind of like what we just talked about. Those who are more spiritual kind of have something to hold on to and something to keep them grounded during hard times and times of stress. And it's kind of a coping way to cope. And the last one is Belgians and information disclosure. This is kind of discusses end-of-life topics with terminally ill patients, and there's always kind of informed discussion about what's happening and life expectancy and the outcomes and the things that are bound to happen. And it's kind of just like all information is given. There's not really anything held back, or they just kind of want to know everything that's going on. Yeah, that is all. Thank you for listening.